Okay.
All right.
So we're starting with photo quiz today. And saw this patient this week.
And this has nothing to do with liver disease.
Yeah.
You can't look at your handouts and get the answer.
But we thought we're going to try to mix it up and maybe do some cases. So I hope you guys are willing to participate in the future and speak up to the mic. So this guy's 80. Just had a birthday and his daughter went shopping for him, bought him some jewelry, and he came in with this thing.
Oh.
What's going on?
Nickel allergy?
Nickel
No,
allergy.
I called her today, said call your daughter. Tell her she's a bum. What kind of cheap watch did she get you?
It's not gold.
No, I did tell him to call the daughter. Why? Dr. Fowler's correct. I forgot he's an allergist in training. So, why did I tell him to call the daughter?
What's the fix?
Yeah, well, how do you fix it? He put it on the other wrist.
Other than
Which I did
That's
not
not a
recommend. What do you guys... clear coat, nail polish. So you can have him coat the back of it, so then the skin doesn't come in contact with the nickel. But he had a nice nickel allergy.
clear coat's a word for nail polish.
Yeah.
It is.
It is, yeah. So I told him to call his daughter up and have her bring by some nail polish to the nursing home, and he could paint the back of it, and he should be just fine. Sometimes you'll see
right up.
belt line,
Yeah.
earrings, necklaces are common areas. Okay.
Okay.
Should we get into it? Today's topic was abnormal liver function test, and really I think probably we should limit it, or we should have probably retitled it just what do you do when you have that patient that comes in and they have a CMP and their LFTs are abnormal? What's the appropriate workup and what should we do? So.
And I wanted to mention this article because it's really good. It's from the guidelines from the American College of Gastroenterology, published last year. I was actually very impressed by it because, you know, guidelines to me are sometimes frustrating because they're like, we can either recommend for or against.
Yeah.
They totally eliminate any art of medicine, but these guidelines actually incorporated when there isn't evidence, what they do as part of the art of medicine. So I thought it was a really good article, and it's worth a quick read, and it reads better than guidelines too. It's pretty clinical. So, all right. So we'll go to our objectives. You should be able to understand the systematic workup of abnormal liver chemistry tests. Be able to do a thorough, cost-effective workup. Know what patient characteristics lead to what type of probability. In other words, which test you're going to do first. And reduce unnecessary referrals to a gastroenterologist.
Yeah.
So.
Sounds good.
Take it away, Dr. Birch.
All right, so I think, like I said, this topic, we probably should have narrowed it to the patient that gets
just a draw.
Gets a lab draw, and I think the one preachy point or the soapbox is that hopefully we should be only ordering labs if we need them, because do you guys know how they construct a normal? Like, what's the reference range for any single lab?
It's just standard deviation, I guess.
Yeah, they bring in, 1,000 people, do the test, and they cut off 2.5% on either end, and whatever's left is. So the statistics is that's 5% is going to fall into the abnormal range, and if you think about a CMP, a CBC, all those individual tests, pretty soon you're going to have a reasonable chance of having an abnormal lab value that may or may not mean anything. Mm-hmm. And then I think one of the things we commonly see in clinic, and the question comes up, is you have somebody that comes in, maybe they had a CMP because they're on a medication and their LFTs are modestly elevated. And I think the question is, what things should we think about working up? There's a whole bunch of things we can do.
There's a lot of expensive tests you can
do. And what's reasonable?
Yep.
You guys have any thoughts? Or so it's the first thing is to construct a good differential, right?
Well, hepatitis versus NASH.
How about, okay, viral hepatitis?
Ben's going for the money.
Yeah, good.
But so, I want to say there's one thing I do first, and that is like look at the pattern, and then is it hepatocellular injury or cholecystatic? And then there's one other kind of subgroup I look at, and that is when it's just isolated bilirubin. What does that mean?
It depends. So you want to know what the direct versus indirect
And
is.
it does, and it can be hepatocellular or cholestatic.
And sometimes the urine test will also let you know with the bilirubin if it's the conjugated type.
Right.
Yeah,
Good.
I had a resident that I was a co-resident would after they were on call, they always had yellow eyes.
Oh, yeah.
So once-
Gilbert.
yeah, exactly. So you can see an elevation there, and it's completely benign.
Yeah, it
Um,
is, and they're always going to be that way. What differentiates hepatocellular versus a cholecystatic pattern in your LFTs?
Alkaline
Alpha.
Alkaline phos
GGT.
has to be elevated right in your cholecystatic. And what other tests do you order to confirm
GGT.
GGTP? Those aren't included anymore, and you
Yeah.
need to order those specials. So
Yeah, because outphos can come from where else?
Bones.
yeah,
Good, where else?
intestine.
Good, excellent. Dr. Jan is on fire. I was going to say only 6% of
Placenta
our
and the
patients
VA.
here women only make up 6% of our population, but that's here at the VA, but that's rapidly changing. And
yeah.
I had a lady come see me for postpartum depression the other day. So alk phos can come, it goes up normally in pregnancy. And so if you have a pregnant woman and alk phos is elevated low, and I would just probably attribute to pregnancy.
And
Good.
also with the ALT/AST2, depends on the levels.
That's true. How high they are. That's a very good point. Whether you're thinking viral hepatitis or drugs or whatever. So.
Yeah, and with regards to the viral hepatitis, hepatitis C is an interesting character, and there's a recommendation out there right now, and it pops up as an alert here. If you're born between these dates, you're supposed to get hepatitis C screening. What do you guys think about that?
Baby boomers.
Yeah, it's baby boomers, but is that a good idea? Why are they making me draw this? This is crazy.
They're healthy.
They're healthy, their LFTs are normal.
We have good treatment for it now.
Before.
So we have good treatment, and the other thing is there is a significant number of people, if you wanted a good sensitivity and specificity for hep C, you'd probably have to drop, I have the thing in my handout. The optimal cutoff would be an ALT of 29 and an 29 or 22 men versus women. Wow. That's like a third of what our cutoff is now, right? So
Goes back to those averages. Things like
Exactly.
What's normal.
what's normal? So a good chunk of these folks may have maybe a chronic carrier, and so you want to pick them up, and we definitely want to treat them now, especially since there were some people in the past, significant mental illness, things like this, you would just scratch them off the list and say you're never going to be able to get treated. But right now that's not true, and the VA
And
has the
also-
money to treat them.
And you hardly ever see acute hepatitis C. It's all chronic, asymptomatic type, and often found incidentally with some mildly elevated liver
And
chemistries.
even having cirrhosis doesn't preclude you from being treated.
That's true.
Yeah.
It's amazing.
I had a guy this week who's got, and that was the other thing I forgot to mention is I also look just to see is the liver working. I think we could have pretexted that by the way we've framed the talk, but
Right.
I always do a quick, is the albumin okay?
Protime.
Protime and those things. But I had a guy this week, we had the talk, and he didn't want to get treated because he doesn't have ascites, but he has cirrhosis, and he thought, since he's got scarring from his hep C, that he didn't want to get treated, and he should be treated, and did, after we had the talk, he agreed to go and be treated. So.
Reduces his chance of hepatocellular cancer.
Yep.
It doesn't totally eliminate it, but it definitely reduces it. So.
Okay. Bad time for a call.
Excuse Dr. Birchwell, we have a commercial. We'll do
It's the daughter, she's
Insert the
mad at me,
Carboni
she's calling
commercial
back
here.
about the bum comment.
She has no nail polish.
Yeah, she's out of clear coat. Okay, so NASH is another one. How do you sort that out?
It's a diagnosis of occlusion. So you have to rule out viral hepatitis and everything else before you diagnose NASH.
Yep,
Ultrasound findings can help.
yep.
Yep.
So I generally ultrasound most of these folks.
I think almost everybody with abnormal
Yep.
LFTs, at least cholestatic, obviously 100%, but
Mhm.
most people. So, the article made a big deal about, which I learned more from that. Really, NASH is a really rare, that's when you start getting fibrosis, and that's only diagnosed by biopsy. And most people have non-alcoholic fatty liver disease. And they're trying to figure it out. They think that there's genetics and different things that make people move on to NASH. But it's not like it's truly, they think of it almost as two separate diseases at this point, which I learned something from. Same subset, people with high BMIs, diabetics, all those metabolic syndrome
Yep.
type of people get the disease, but for some reason, most people luckily with fatty liver disease do
Yep.
not go on to your cirrhotic NASH or
Mhm.
fibrosis NASH, which goes on to cirrhosis. So.
And sometimes I know we think of, yeah, exactly, I think only like 5%
Right.
progress, but it's gonna be the leading cause for transplant coming up
Yeah,
rapidly.
just because it's a
Yeah, and
endemic, obesity
uh,
is endemic.
I've had several people, BMI's 29, and they have elevated LFTs and they have NASH. I think that's a different bucket, and we're not sure
Yeah,
why certain people. We actually had a friend of the family who's a PA died last week, and he had NASH, but his BMI was like 26.
yeah, that's not right.
And he never made it to transplant, but there's not really good treatment for NASH other than weight loss, and we're not sure which people to aggressively pursue.
Right.
See,
Hopefully there'll be a genetic test eventually.
yeah.
So I think when you're doing your workup, so let's say we've decided it's a hepatocellular injury. Now what you want to do is not shotgun everything, but start looking at your patient characteristics and decide what you're going to order. But let's first say, what should everybody be tested for? Obviously, we've already talked about it a little bit.
Hepatitis B and C.
Yeah.
Yeah, good. So
Your viral hepatitis should be tested for. So
rule 1 of medicine.
yeah,
If you don't know it's either a drug or a virus.
that's true.
So viral
And so
hep- what
virus
about
has to go.
What drugs do you want to look for?
Tylenol.
Good, acetaminophen, antibiotics, statins,
Yep.
NSAIDs.
NSAIDs, yeah.
There's a whole slew of them. And then there's another one that I put as a medicine. Alcohol,
Yeah.
very important.
Is it a medicine?
Some people, I guess. Well, you can prescribe it, right?
Yeah.
You used to be
That's
able to
true. I
prescribe
used to be able to write 3 beers TID. I don't write that very often anymore. That was a VA thing.
Yep, it was.
Prevent alcohol withdrawal
You
with
could give them
alcohol.
your.
Yep. Might
So
still be safer. We should study that. sometime.
drugs.
Not personally.
Plenty of volunteers.
Yeah, exactly. That's finally a study med students want to be part of.
There you go.
So after viral, what is the next most common cause of hepatocellular injury? Again, we just talked about it.
NASH.
Yeah.
Yeah.
So then starting to do your ultrasound for that, and then after that, what's next? We just talked about it too. Wow, we're just like
Yeah, we're speeding through.
drugs,
Alcohol.
alcohol being the
Yeah.
biggest one. And it doesn't. How many drinks does it take to get alcoholic hepatitis? It varies for women and men, but
More than 3 in men a day on average.
yeah. So actually, the cutoff.
It's higher than that. It's like
10
6 to 7.
According to this American a day.
Yeah.
Ooh. According to this
Ben
American
knows how to
College
just
of
get under the limit.
He's having 6.
I should be good.
Yeah.
Stop at
My
5.5.
liver's healthy. According to these guidelines, it was a lot lower than what I've seen before, and that was 10 drinks a week in women and 21 drinks a week in men. So it was about the 3.
3 a day.
Yeah. So, and that, I don't know if that's like over a time period or something they didn't mention, but they said if you have a patient that is drinking that much, that makes your diagnosis that much likely for that. So,
Yep.
that may be factored into the rule. I mean, Ben may be more correct, but patients often
They tell you
underreport.
3 and maybe they're drinking 6.
Right. Right.
What other common things should we think about? Oh, I got the bronze diabetes.
Hemochromatosis.
That's your next one. Yeah.
Oh, that's not likely. They don't have the bronze diabetes. They're not bronze, they don't have diabetes. I'm not going to worry about it.
We don't
Are
let
they
it come
young
that
and
far.
have arthritis though?
Yeah.
And, I actually,
Or gonadal dysfunction or cardiac dysfunction.
we'd like to catch them before they get to
Right.
that point. Because a lot of that is fibrotic.
And they do start getting damage.
What was the family history?
Yeah. I actually screen, if you have abnormal LFTs, I screen for it. How would you screen for hemochromatosis?
You can do a
Ferritin.
bunch of labs.
Iron.
Ferritin.
Yeah.
Transparent saturation.
Yep, transparent saturation. Really easy. You can add it on to if they had a CMP, they can add that on. And it'll be back within an hour.
Yeah.
And you're looking for the TSAT above 45%, then you want to think about doing the genetic testing.
Yeah. What if it's a person with like rheumatoid arthritis or something for another type of diagnosis?
Autoimmune disease can affect
Yeah.
the liver.
Oh my
Carries
gosh.
autoimmune or even like a Graves or something. The person is more prone to an autoimmune hepatitis. So
And there's all those antibodies. There's antimitochondrial, LMK. Which ones do you draw?
type 1 is anti-smell muzzle.
Yep, that one's in there too. Straw mall.
Gotta talk to them about the rest of their symptoms.
What's a quick, easy screen we could do? Any thoughts?
DNA.
DNA.
I do a serum protein electrophoresis. What's that?
Oh, that's good.
So they take the serum and they draw it across an electrophoretic panel. If they have elevated gamma globulins, then I start looking at, then I have them come back and look into more history. The other thing about an SPEP is they also have an alpha-1 peak. They should.
Oh,
What if the
that's
alpha?
useful.
What if the alpha-1 peak is missing and they have elevated LFTs?
Anti-1 alpha-trypsin.
Yeah,
Yeah.
then I have to go get up to date and figure out which one it is.
Which is okay,
Yeah,
as
it's
long as
okay.
you get there. What if they're less than 55 years old and you've eliminated all those other things? What's a fairly rare disease, but in young people you got to worry about it with
Wilson.
Wilson's.
Wilson's disease.
How does Wilson show up? There's a couple of ways.
Oh, psych. It could be confused with a psych.
I have one
Neurologic psych,
in my
yeah.
panel, and he is
Crazy
wow,
as a balloon.
yeah, a handful. The other way is hemolytic anemias. They can they get a hemolysis, and I can't remember the mechanism, but those are two ways. And a lot of times, once they get the psychiatric symptoms, that's it. So we want to catch that early.
Right.
And I didn't see in the guidelines. Do they recommend screening
For Wilson's?
Wilson's up front? I generally
Maybe,
don't.
no, not up front. This kind of workup is very stepwise. You keep going from the most common to the least common. So if you get to somebody with hepatocellular injury and you've eliminated all the other ones, that's when you would consider it.
Yeah, I usually do an ultrasound, viral
Yeah.
hepatitis panel. I do an iron binding, and a serum protein electrophoresis. That's enough.
Yeah, you don't need to do all these all at once. It's just like, oh, I eliminated all that. Now I need to go down here to look at my less
Yeah.
common type of things. One thing I forgot to mention about drugs that people are doing all the time. What is it that we should be asking them for, drugs wise?
It can't cause me any trouble.
Supplements.
It
There's
came
no
over the-
side effects.
It's an
Yeah,
herbal.
supplements.
What could go wrong?
All these super mega fatty,
Yeah.
fat soluble vitamins, all those things. And a lot of the Chinese herbal medicines getting very popular here, and that can cause a lot of, actually can cause liver failure in high doses. And people love to take more is always better, right?
Exactly. It's America. Maybe it's better.
It is. Okay, so if we go to cholecystatic, only a couple diagnoses,
Yep.
right? What are those?
Gallstones.
Yeah.
Malignancy.
What's that?
Malignancy.
Yeah.
Malignancy, absolutely. Always image.
Primary biliary cirrhosis.
Primary biliary cirrhosis, yep. That's always it. And then primary sclerosing cholangitis. So not a big workup there. And then, like I said, the bilirubin. I see people ignore, kind of mildly elevated bilirubins, but I think we should at least, see if it's conjugated and then start working them up from there. So,
Yep.
yeah.
Can we
That's
sum
it.
it up real quick? These guys gotta see patients.
They want to see patients?
They do.
First-
They just want to get away
Check
from us.
LFTs.
But I can't blame them. First, differentiate between hepatocellular patterns and cholecystatic patterns. In the hepatocellular pattern, start with your most common diseases first, and then work from high probability to low probability, which means, do they have other autoimmune diseases? Do they have bronze diabetes? Whatever leads you to do the testing. Imaging with an ultrasound is almost always indicated. And if no etiology is found after thorough workup, refer the patient to GI. They most likely will need to do a liver biopsy. Most people, if you're going to stop probably at the non-alcoholic fatty liver disease. That seems to be where we're
Yeah.
seeing it now.
I can't remember the last time I couldn't figure out
I know.
LFTs. So.
Yeah. So it would be rare. All right.
All right, go to work.